right, I'm curious about, I'm curious about if my PowerPoint's gonna load up. Let's see. Oh, it's good. All right, perfect. All right, I was not anticipating that. So thank you for having me again to talk about a topic I'm actually very passionate about, and frankly, we've been talking about lung cancer a lot today, so transitioning to some of these non-malignant diseases and therapies is really exciting to me. So I'm going to talk about endobronchial valves and BLVR and how it really incorporates to the new paradigm in terms of how we treat emphysema. So these are my disclosures. But again, I'm talking to a room of pulmonologists. When I talk about emphysema, this is not a new thing to us. Okay, when we look at the healthy lung with regards to the functionality, we obviously understand the oxygenation standpoint in addition to the ventilation, but really we think about it as a big rubber band in a lot of ways. And as opposed to normal lungs, when we see emphysematous lungs, we see overinflation, hyperinflation in a lot of patients here, in addition to some of the chronic bronchitis perspective we talk about. But really what we want to understand is why are patients short of breath or dyspneic when they end up having hyperinflation of the lungs after cigarette smoking, or in some cases alpha-1 antitrypsin. And really what we think about is a normal lung and a hyperinflated lung. And we talk to our patients about this all the time, that a hyperinflated lung is pushing down on their diaphragm, and as opposed to normal lungs, which move up and down in terms of generating negative pressure, the hyperinflated lung is pushed down. And as a result, it's not moving as efficiently as it could. And we require other muscles, chest muscles, neck muscles to actually breathe. And as a result, there's less diaphragmatic curvature, there's more work of breathing, and I tell my patients it's like you're at the gym 24 hours a day and you're just exhausted, and that's why they're short of breath. The problem we run into is not necessarily just the actual changes in the dynamics of people with emphysema, but it's a spiral. And we know that patients start getting sick from their emphysema, they're short of breath, so they start doing less, they have less exercise. As a result, they do even more kind of sitting around because they're short of breath, they get more deconditioned, and that's when we see the increase in mortality with these patients. So really the hope is to try and get them more active and get them back to their functionality that they had before. Okay? So when we think about treatment options when it comes to emphysema, there's been movement over the last few years, but really the main approach is based on pulmonary rehabilitation and inhalers, and those are the less invasive approaches. When we think about the more invasive approaches, we think about lung volume reduction surgery, in addition to lung transplantation, which in my mind I think about as exchanging one disease for another, meaning you went from emphysema to having a lung transplant. And what we end up seeing is that still the 5-year mortality associated with lung transplant is still only 50%. So is there something in between? Can we find something in between? And really what we look for is that less invasive approach that can emulate some of the things we talk about with regards to reducing hyperinflation. And this is where endobronchial valves come in. Okay? Now, endobronchial valves are small implantable devices, sometimes the size of my pinky fingernail. And what we look for is to emulate the results of lung volume reduction surgery by decreasing the amount of hyperinflation, by removing the more injured part of the lung, removing that part and allowing the flattened diaphragm to become more curved and then able to move more effectively. And the benefit of this is not only can it be done in a situation where patients who are already sick with emphysema have a lower morbidity and mortality, but also it's reversible if we run into a situation where a patient isn't tolerating it. So how is the procedure performed? Really what it involves after a significant workup, and I'll talk about shortly, a bronchoscopy is performed to go into the airways and place small one-way valves into these lobar bronchi. Now they're one-way valves, so air removes to the central airways along with secretions, but no air is able to move into the lung, the lobar that's treated itself. The benefits of this is you get deflation of the lung. I don't say collapse of the lung because appropriately it freaks our patients out. So when we look at what the criteria for lung volume reduction procedures bronchoscopically, there are some data that's based on a multiple randomized studies. Really what we look for is hyperinflation based on RV and TLC. And finally, we also look at the question of what their FEV1 is. But there are also other aspects that we have to take into account. Is the patient functional? Or, a patient who's been in a wheelchair for 3 years, then getting valves is not going to be as successful a case otherwise outside of the objective measures. My goal with valves when I talk to my patients is saying, what can you do? What could you do before that you can't do now, and what can we get you back to? I tell them, you're not going to be running marathons, but can I have you getting dressed or having a shower without being short of breath? That's an appropriate goal. Can I have you play with your grandkids without getting as short of breath as you are now? That's an appropriate goal, and that's what we're seeing. Now, there are some exclusion criteria, but the main exclusion criteria we look at is the ability to diagnose pulmonary hypertension. Patients who have severe pulmonary hypertension typically are not going to tolerate this procedure well. I will say, based on echo, if there's a indication of pulmonary hypertension, we typically almost always get a right heart cath because we don't always see that pulmonary hypertension on the cath itself. So again, how it works is these valves are placed, the air moves out of the valves, and you reduce the actual hyperinflation, and diaphragmatic motion is improved. This is a quick video of how it's performed. And I will tell you again, the placement of the valves is not a challenging procedure. Physicians who do bronchoscopy on a regular basis, it can be done with relative ease. It's the workup and patient selection along with the lobe selection that's the most important. So after these valves are placed, air can no longer go into that segment, but air comes out and we see deflation. This is what the valve looks like in the lower corner, opening and closing as it deflates. Now this is a great sign to see because you know the lobe is starting to deflate. So this is a patient that we had done, and this left lower lobe valves are placed on this patient. You can see the flattening of the diaphragm on the x-ray on the left. On the right, you see that diaphragm to come back up. It's actually functional now, and as we see the curvature we're looking for with the appropriate atelectasis and pullover of the trachea. A number of steps are involved in this. When patients come to us and say, I want valves, I say, I'd love to give you valves too, but I want to make sure it's going to benefit you. I have to make sure that you're going to actually benefit from doing this procedure. And really what it is patient selection. Two of the aspects we think about are not only hyperinflation, but I'll talk about shortly fissure completeness. The next thing is we chartist, meaning we look for fissure completeness during the procedure prior to putting in valves, and finally the valves are placed. The biggest part of what we look at also is looking at patient functionality and activity after valves are placed. This is not a procedure where you put the valves in and we never see them again. We follow them on a regular basis, and frankly, I get them back into pulmonary rehabilitation and exercising so they can do more, get stronger, and become less dyspneic. This is a video of the valve going in. We're going up to the left upper lobe. You can see one valve is already in. And here's deployment catheter. And as opposed to spiration valves, which go into the airway itself, these are actually minimally deployed prior to complete deployment. The valve is rested on the carina and then deployed. There you go. And I'm going to say it's sweet when you see it deploy the way you want it to, and the ductbill is opening, closing, and venting. That's really what we look for. So patient selection. Now, a lot of this patient selection we use in the United States is based on the Liberate trial, which was kind of the pivotal trial that got us through the FDA. Now, I'll talk about shortly, there are other ways of looking at the inclusion criteria. We need a CT scan to actually do a STRATIX assessment, which gives us a breakdown of the actual tissue destruction, the fissure completeness, and the hyperinflation. That fissure completeness is confirmed during the procedure prior to placing the valves, and then valves are placed. This is an example of the STRATIX report that comes off the high-resolution CT. It gives us a display graphic that shows us the destruction, the actual fissure completeness, and then hyperinflation. Fissure completeness is on a score of 0 to 100. And again, I implore people that when they start doing this in the future is to not just look at the actual graphic or the report, look at the CT itself, make sure that there's actual fissure completeness from your visualization in addition to hyperinflation. The destruction score is based on Hounsfield units of negative 950 and negative 910. That's typically at a breakdown of either 50 or 25 respectively, shows an adequate destruction to target that lobe. And finally, inspiratory lobar volume, the amount of volume in the lobe that you're going to be targeting. Now, one of the biggest factors that we look at is actually making sure there's no collateral ventilation. And that means, is there communication via the pores of cone between lobar bronchi and the lobes. If we see that, if we see communication between those lobes, it doesn't matter if we put a valve in the best possible way in the left upper lobe. If it's getting ventilated from the left lower lobe, you're not going to get at lobar atelectasis, you're not going to see improvement in diaphragmatic function. So really what we're looking at is something that's CV negative, collateral ventilation negative. This is the StratX, and this is an example here of how the StratX is performed, where we look at the actual, it's a balloon with a flow sensor at the end of it, and really what we're looking for is reduction in flow, and you can see that on the, over to the right on top, where we occlude the target lobe, and we see flow going down very slowly. The reason for that is because there is no collateral ventilation coming from the ipsilateral, non-treated lobe. And as a result, you see cessation of flow. Whereas in the right lower part, you'll see with collateral ventilation, flow will continue, because even if you close off the left upper lobe here, you'll get flow from the left, the left upper lobe, you'll get flow from the left lower lobe, and flow will continue. Again, this is a good example of a CV negative patient on the left and a CV positive patient on the right. So what does the breakdown come out to when we look at these analyses? So if a patient is 95 to 100% fissure completeness, there's only about a 15% chance of getting the CV positivity. So we still test all of these patients, even if it shows on their analysis, it's 100%. 90 to 85%, 80 to 95%, there's a 50-50 chance they might have collateral ventilation. So we make sure we test these patients appropriately. And less than 80%, it's likely going to be CV positive. I typically don't offer a bronchoscopy or chartis for this. So a ton of data has been coming out for this. Now I'll tell you that when I was a chief resident in Chicago in 2009, I gave my grand rounds before finishing my chief residency that valves are coming to the United States any year now. That was, a little 9 years too early, because they finally came out in 2019 based on a wealth of information in addition to the Liberate trial. And really what that showed is there was an improvement in lung function in treated patients who got complete lobar atelectasis by about 18%. Exercise capacity improved by 39 meters, and the St. George questionnaire improvement of about 7 points. Now, Liberate was a multi-center study. It looked at a number of patients, and really what we were trying to identify was it was the fourth RCT in CV negative patients. And what we really wanted to identify, was there a minimal improvement in terms of functionality and number improvement. Now this is the actual slide in terms of the outcome. I like to generalize it here. In all comers, comparing them to patients who had valve versus patients who had the standard of care, there was improvement of RV reduction, improvement in FEV1, improvement in functionality based on the St. George questionnaire, in addition to 6-minute walk. And this is what it kind of translated into. Improved health status, and I'll talk about that shortly. Improved quality of life, reduced breathlessness, improved lung function, less gas trapping, especially when there's successful lobar occlusion. So this is an incredible change in terms of what we looked at. It's not just an option of lung transplant or a lobar LVRS. We have something that's minimally invasive that can improve outcomes. And frankly, we've seen that patients who actually underwent the treatment had much more satisfaction in their functionality. Now, one thing we talk about, this is not just for people who are incredibly ill, we have no other option. It's part of the GOLD guidelines. It's a level A evidence. So physicians very rarely remember that this is an option for their patients. It's not experimental anymore. It's part of the treatment algorithm, and it should be considered in patients who are dyspneic after maximized therapy. Now, there are some risks associated with this, obviously. One thing we do see is pneumothoraces, and we can see an ipsilateral pneumothorax on the treated lobe in about 26% of patients based on the Liberate data. There were some deaths in this and associated with Liberate, mainly because patients were sent home, they had a pneumothorax at home, and as a result, they had a mortality. But really in the United States, there's a requirement that patients have to stay in the hospital for 3 days because frankly, 76% of the pneumothoraces occur in those first 3 days. So if we can be available, put a chest tube in and take care of this, the improvement in quality is significant. While most institutions worry about the pneumothorax, I don't even consider it a complication anymore. I consider it part of the therapy and we have to deal with it. Really what we worry about is keeping those patients in the hospital too long after the pneumothorax secondary or persistent air leak. Our institution is very comfortable sending a patient home with a pigtail catheter on a mini atrium, and we looked at about 24 of our events. When we send them home, we teach and educate the patients how to detect a persistent air leak. They go home and we follow them every week on a video visit, and we tell them, look, is your air leak gone? And if the air leak is gone, we'd say, come on in, we're gonna take your tube out. If the air leak is still there, we say, okay, next week let's talk again, or call us when you're ready. So we looked at this in terms of what's the incidence of empyema in these patients we sent home. And secondly, we looked at what was the number of days on average, because as long as we're open about with our patients about what the risks and what the likelihood of occurrence is, patients are never upset with us that they got a pneumothorax or that they're going home with a chest tube, as long as they're feeling better. So what we saw was patients on average were about 17 days having a chest tube, meaning the day the chest tube was put in, and it's almost always a 14 French pigtail, till they go home and the chest tube is removed. So after about day 3 or 4, as long as they're on water seal, we get them home with that chest tube. And the incidence of empyema was only 8%. Now, the surgical literature looking at following lobectomy, going home with a chest tube, is anywhere between 18% to 34%. So this is pretty good still, and we watch these patients very closely. Now, one question we also ask is that we're very strict initially in starting these programs in the United States, and you've got to follow the Liberate criteria. You've got to have an RV of 175. You have to have a certain FEV1. Really what we looked at, real world data for us, at looking at about 150 of our cases, is that you don't have to have a RV of 175 in order to get improvement, especially if you have significant dyspnea. So we look at our patients and we say, look, it doesn't have to be 175. If you're at 155 but extremely dyspneic and you have hyperinflation, we're going to treat you. And what we saw was in our patients, there was a significant improvement in FEV1 compared to Liberate, and we were about 28% improvement versus the 18% improvement. And this is based on heterogeneous disease. When we look at our exercise capacity, it's very similar, slightly lower than the Liberate criteria, but what we really focus on, my goal is to improve their functionality. And when we look at quality of life based on St. George questionnaire, there's a significant improvement in our patient population, not holding just to the Liberate data, of close to 18 points improvement in their St. George questionnaire versus 14. And those are in heterogeneous disease. If we look at homogeneous disease, while there might not be significant improvement in their pulmonary functions, looking at FEV1, there is again improvement in their quality of life, and that's really what I care about. There's also indication that there's survival improvements with valves. Looking back retrospectively at our some of the patient populations, patients who got atelectasis had a slight improvement in their long-term survival. Additionally, looking at some of Hartman's data, randomizing patients and following them longitudinally, we did see patients who had significant hyperinflation. There was a survival benefit when valves were placed. So what we talk about is patients who have severe hyperinflation, there may be an improvement in life expectancy, but patients compared to untreated, there is an improvement in terms of survival based on retrospective data. We have some of the main investigators with CONVERT here, and CONVERT, the goal is that not all patients, again, will have complete fissures. So patients who don't have complete fissures, is there a way of dealing with this? And what is being looked at is really placing AirSeal, which is a sealant, into those patients' target lobes and see if we close off the fissure. An AirSeal is a polymerizing sealant. When this is closed off, then the fissure is complete and we can place the valves in. And what we end up seeing, there's an improvement in terms of the patients who become CV negative after CV positivity, and there's an improvement in terms of improving lobar collapse and improving FEV1 after placement of these valves in those patients. So this is really what we're looking for. But at the end of the day, what I ask my patients, what do you want to do? What do you want to do if you want to feel better from your emphysema? And we have very good outcomes in patients, but the one that stands out to me is the guy on the left. His name is Charlie. He had real trouble walking from the bathroom, from his bed to his bathroom. When he's short of breath, would have to sit and talk and rest for about 10 minutes. I asked him, what do you want to do if you get these valves? What kind of activity you want? And I'm thinking the guy's going to want to be able to, take a bath and not be short of breath. He told me he wants to go swimming in the ocean. And I'm like, come on, man, I don't know. Swimming in the ocean might be a little aggressive, but we can get you feeling better. So we did his valves in July. He did really well. New Year's morning at 7 a.m., 6 months later, he calls me. And I'm like, it was New Year's, man. So I was a little bit hungover. The kids were jumping around all over the place. And he called me and said, look, Bobby, I just went swimming in the ocean and it felt great. So we do see these cases. Not everyone is like that, but really what I look for is to improve functionality. I also say it's not a single physician, it's a program. This is not a procedure you do, it's a program. You work these patients up, you do the procedure, and you follow them longitudinally. Because if there's an issue or a question about the valves, you want to be that person helping out. So this was after our 50th case, it feels like forever ago. But these are all the people involved in our program, meaning on the left, our lung navigators, a little bit to the right are our respiratory therapists, our anesthesiologists, our physicians, and our rehab group. So really, this is a program that can help patients, and I want to bring this back to, from the India perspective, there's a ton of emphysema here. There's a ton of patients who could benefit from this, and really one of the goals is to try and bring these valves to India to improve some of the functionality in our patients and give another option for those who have emphysema, who have exhausted all their medical therapies. So I want to thank you. This is my information if there's any questions, but again, it's a really exciting time for treatment of emphysema, and frankly, I think that improving the functionality of our patients should be our real goal in the long run. So thank you very much.